you. Thank you. Alessandro, you are on mute.
Stella, do you hear me?
Now, yes, Alessandro.
Do you hear me?
Yes, yes.
Okay, good. Okay, can you confirm again that you can hear me?
Yes, go ahead.
Okay, thank
All
you
is
very
good.
much.
Yes, now we can hear you.
Okay. I just told you that I was very happy to have you in this Italian afternoon to study together one of the most interesting and important subjects in the field of low-dose medicine, which is exactly how to manage and lead the immune system function with our low-dose pharmacology, meaning for that both the use of single low-dose cytokines or multi-component medications. And this is what we will do together in terms of educational agreement. First of all, we will start spending no more than 10-12 minutes in order to provide a systemic and synthetic view of the immune system, which is absolutely mandatory in order to understand the very sophisticated way our single cytokines work. We will focus especially the attention on the innate immunity and on the cell-mediated immune response. And you will understand immediately why our attention will go mainly on that. For sure, we will spend so long time to understand any single low-dose cytokines, but we will study also multi-component medication such as Cytomix, GUNA Flan, GUNA Flu. We will understand the two sides of the immune moon, the immunostimulation and the immunomodulation. And we will see also some protocols to manage infectious, inflammatory, and tentatively, if we will have time, also allergic diseases. For sure, every information I will provide will be supported by the results of our research, both preclinical and clinical. We will not speak about all the so numerous products we have in our bag of tools, but the bag of tools of today will be mainly focused on these ones you are seeing in this slide, from interleukin-4 to anti-interleukin-1, from Cytomix to GUNA Flu. But believe me, we will go for each one of these products really in very, very deep way. Let's start speaking about the first side of the immunitary sky. I will share with you what we have observed, what we have experienced to manage infections and how to strengthen the immune system. But what is unique, really unique in our proposal in infectious disease is that we can stimulate without inflaming, and we can manage and reduce the inflammation without immunosuppressing. This is absolutely important because with conventional pharmacology, when in the viral phase we immunostimulate, very often we provoke an inflammation. At the same time, when we are managing the post-inflammatory phase, just think to corticosteroids, for instance, we absolutely reduce very well the inflammatory status, but we also immunosuppress. With low-dose pharmacology, we will reach this goal. And what is the same so interesting is that we will be able to act before in terms of immunoprotection and prevention. We have a wide range of products to manage all the different phases of the acute inflammation, which is related with a, for instance, viral infection. And we will have also some solution in order to manage the convalescence of the patient, which is the same important, and very often, apart our pharmacology, we don't have so many other solutions. But speaking about immunology, we always have a certainty that will be very, very difficult. That's implicitous in the complexity of the immune system. In this slide, just to have an example, you can see a part of the Th1 pathway on the left and a part of the Th2 pathway on the right side. And these are only little parts of the complete immune system. So I will try with you to be absolutely precise, but also very easy to be understood. The first concept under the form of an image I would like to transfer to you is that this complexity of the immune system is a sort of an orchestra where you have many soloists, you have one director. Well, the same is in the immune system. So we will see soloists and directors, and we'll also understand that very often, it's better to work in terms of an orchestra. Just think of cytomix, just think of GUNA flu. But sometimes we also need the solo of the soloist. Well, this is what we can offer with our low-dose pharmacology. The title of this webinar, The Secret Orchestra, it's not mine. This is a wonderful book I strongly recommend to you, written by the most important Italian immunologist named Alberto Mantovani. This is a beautiful book because he describes in a sort of a movie what happens inside of our immune system anytime we have an immunological disease. So let's go to understand the basis of immunology to understand how to use in the right way our medications. By a scholastic point of view, as you know, the immune system can be divided, but just and only in a scholastic way, in two parts: the innate immunity and upper side of the slide, and the adaptive immunity. In the reality, there is not this dichotomy between the two parts. They are quite different. For instance, just to have some hints, The innate immunity, it's very fast. It's the first front, but it is transitory. It doesn't have any memory. It's interesting that it is genetically transmitted. So under some ways, we are the consequences of the immune system of our parents. The adaptive immune response is more sophisticated. In fact, it is also a little slower, but it is very stable. Just think of the memory of antibodies. It is totally individual, and there is a genetic adaptation. So they cooperate, obviously, together, but they are very different. The first part I want to focus with you is about the innate immunity. And with our medications, we work very well on this part of the immune system. This is just a little mechanics of the immune response in terms of innate immunity. A pathogen, a virus, a bacteria, goes inside of the systems of the body. Immediately, it is recognized by some circulating immune cells. The first ones are the macrophage. They are able to recognize the not self and to phagocyte it in order to directly eliminate the pathogen, or through the production. Oh, look, the first time we are naming our medications through some cytokines, for instance, interleukin-12 and gamma interferon, able to activate natural killer cells. Well, they are able to destroy, to attack the infected cells, eliminating them. Our macrophage are also able to do something a little more refined. After phagocyting the antigen, the pathogen, they destroy the pathogen, producing some little molecules named PAMPs, pathogen-associated mediators. And these parts of the pathogen can be recognized by a very important cell. Please pay a big attention on the role played by the sister of the macrophage, which is the dendritic cell. In fact, through some machineries named toll-like receptors, dendritic cells are able to bind the PAMP, to internalize it, and to expose through another very sophisticated machinery named major histocompatibility complex class 2. They are able to present to someone, we are going to see who he is, this someone, the antigenic part of the pathogen. So you have already saw that there is a cooperation between the first two important type of cells of the innate immunity, macrophage and also dendritic cell. Why I ask you to be concentrated and focused on the innate immunity? Because you can see this paper, 2020, New England Journal of Medicine. The same immunologist, the Italian immunologist Alberto Mantovani, published this paper saying that innate immunity represents 90% of our defensive immunological potential. So if we will have some tools after the form of medications, active and safe, how our medications are, we will do something really important for the patients, especially in terms of immunoprotection and prevention of infectious diseases. So, speaking about innate immunity, we also have to know how this innate immunity is made. First of all, part of the innate immunity are the anatomic barriers. Just think of the skin. Just think of the mucosas. we have the mucosal associated lymphoid tissue, which is a big part of our immune system. But also physiological barriers such as lysozyme, interference, and complement are part of the innate immunity. Through some cells, such as macrophages, neutrophils, natural killer cells, we are able to provide processes named endocytosis and phagocytosis. And never forget that inflammation is a part of the innate immunity. But once again, there is this beautiful, wonderful cell, which is the dendritic cell, which is between the innate and the adaptive immune response. And it plays a crucial role in the dynamic of the immune response. Let's see now together what the dendritic cell does. You remember, being an antigen-presenting cell, through the major histocompatibility complex class 2, it is able to present a little part of the antigen to a cell, which is the first director of the orchestra in the immune system. This cell is the T lymphocyte naive. You can also call it CD4 naive. What does it mean, naive? It is not yet differentiated. And according to the type of antigen presented by the dendritic cell, and even more by the cytokine milieu, the CD4 naive will differentiate in some specialized lymphocytes called Th1. Th1 are the effectors of the cell-mediated immune response. So they will be one of our main targets in low-dose pharmacology. But when Th1 are overexpressed, they can be the effectors of inflammation. So you can see in this slide that written in red is the bad part of what these cells can do. In fact, one of the main rules to understand the immune system is in it doesn't exist neither the good nor the bad. It depends both for cytokines and for immune cells by their expression. If they are too little or too much in comparison with their homeostatic physiological expression, they will be not absolutely good. CD4 can differentiate in Th2, which are involved in the...
Alessandro?
Yes.
Sorry, we lost the presentation.
Okay.
Now you are screening something in Spanish, maybe someone else.
Okay,
I don't know how can happen. How can that happen?
Okay, wait a second. Do you see my slide now?
Yes.
Yes.
Okay.
It is pretty.
Honestly, I don't know what happens because I'm just speaking.
Okay.
All right. Okay, so did you hear me when I was speaking about Th1?
Yes, we heard, but we didn't follow the presentation, the slides.
Okay, so I repeat.
Also, there are some people who did not mute their microphone, so we hear some voices from outside.
Yeah, exactly. Someone.
Yeah, so
we
it's
can,
not good. We cannot follow.
Yeah, maybe we can mute all. We can do it from here. Okay.
Okay, good. So let's go a little back. We are speaking about the adaptive immunity, which is led by this director of the immune orchestra, which is the T lymphocytes, naive. What does it mean, naive? It is not yet differentiated. Look that in literature, you can find this immune cell also named CD4 positive. CD4 positive naive, according to the antigen presented by the dendritic cell, and even more by the interleukins milieu in the environment, will differentiate itself in some specialized T subsets named Th1. Please, this is very important for us in low-dose medicine because these cells are one of the targets of our medications, those ones we are going to see. Th1 are involved in the cell-mediated immune response. But when overexpressed, you can see that some words are written in red. They leave their good activity, cell-mediated immune response, and they acquire their bad activity. In fact, when overexpressed, Th1 are involved in inflammation. Th2 are the effectors of the humoral immunity mediated also by antibodies. But if overexpressed, they become the actors of allergy. Th17, they are quite recent in terms of discovery. They are beautiful when we don't have them so many because they are involved in tissue damage repair processes, or they are able to defend us versus fungi. But we need to be very careful with these guys because when they are overexpressed, they are markers of autoimmunity. Very important also, the subset of T cells named T regulatory. They are a sort of controllers of the immune homeostasis. They are involved in the immunotolerance, but when overexpressed, they are responsible of severe immunodeficiency. For instance, in patients with carcinomas, normally they are overexpressed. And being overexpressed, they leave their good activity of immunotolerance, and they become the guys able to downregulate both Th1 and Th2. The result is that the cancer patient is dramatically immunosuppressed. Last but not least, in this chat we are having about the immune system, are the T follicular cells. They are quite important because deeply involved in the maturation of B lymphocytes at the level of the lymph node. But when overexpressed, they are involved, even them, as well as Th17 in autoimmunity. Look that if you know not all the immune cells, but these 5 different immune cells, you will be able to understand very well the mechanics of the immune response. This is a slide that I love very much. You will see there are some animation because it shows the pathways of lymphocytes maturation and circulation. Let's start seeing what is related to T lymphocytes. In the thymus, we have the T precursors. They are almost unuseful because they are not mature and they are not able to defend our body. From the thymus, T lymphocytes are released under the form of CD4 positive indifferentiated, naive. They reach the tissues, especially the extracellular matrix, and through the lymphatic vessels which vascularize the extracellular matrix, CD4 naive reach the lymph node. And now in the lymph node, we have a good population of CD4 positive naive. For what it concerns the B lymphocytes, they are in a sort of reservoir in the bone marrow. They need to be released continuously, more or less every 1 to 2 weeks, and they reach the tissues. The same through the lymphatic vessels. Even the B cells reach the lymph node. So now the real most important part of our body is the lymph node. Come back to the CD4 naive.
You are muted. Alessandro, you are muted.
Okay, do you hear me and do you see me?
Yes.
Yes, now we see.
Okay. Okay. When did you lose me? I was already.
You told that the lymph node was now the most important part of the immune system.
All right. Okay, so let's see what we are used to observe. And after the presentation of the antigen by the dendritic cell to the CD4 naive, it undergoes indifferentiated subclones, which are those ones we already have studied: Th2, T follicular, Treg, and Th1. Very important is the cell-mediated immune response, which involves Th1. Through interferon gamma, Th1 activates CD4 positive, another family of immune cell, to become T cytotoxic. Part of them remains into the lymph node under the form of T cytotoxic memory. But what is important is that the T cytotoxic, which is now activated, is released out of the lymph node, and it reaches the tissue where he has to exert its defensive activity, which is mainly, for instance, to destroy the cell infected by the virus. Interesting is also the cooperation between other T subclones, Th2 and T follicular, in the humoral immune response, which is, as you know very well, mediated by B lymphocytes. In fact, Th2 are involved in the activation, the final activation of B lymphocyte. And it happens via interleukin-4. So you are already becoming confident with these glycoproteins, which become for us medications. Also, T follicular are so important because they are involved in the maturation of B lymphocytes. To be more precise, they allow the B lymphocyte to become a plasma cell able to produce antibodies. And these antibodies will be released out of the lymph node to reach the tissue involved in the disease. A part of the B lymphocytes, as well as T cytotoxic, will remain in the lymph node under the form of B memory. So you have seen the involvement of some cytokines, gamma interferon, interleukin-4, interleukin-6 in the leading of the immune response, both cell-mediated immune response and humoral antibody response. I told you now the most important organ is the lymph node. Everything now happened in the lymph node. That's the reason why sometimes we need to think of a very important multi-component medication, which is GUNA lympho, when the lymph node is involved in the immune response too much, and its phenotypic outcome is this adenomegalia, is the hypertrophy of the lymph node. In order to drain the lymph node, always we have to think in terms of GUNA lympho, providing 20 drops twice a day until the phenotypic outcome, the hypertrophy of the lymph node, will disappear. Interesting that there are different zones for the maturation of T cells and B cells. I mean, the lymph node is really a crucial structure for our immune system. So speaking in terms of anatomy of the immune system, and we are creating robust basis in order to understand when and how to use our single cytokines or our multi-component medication. Once again, the dendritic cells present the antigen to the CD4 naive. In that moment, the CD4 naive become activated CD4 naive and start the differentiation in Th2 humoral antibody response, which is the main way followed by the vaccinations, and Th1, mainly involved in cell-mediated immunity, which is the way we, as low-dose medicine, prefer to follow. Cell-mediated immune response, humoral antibody response. Why this premise? Because as you have seen, everything is commanded, is led by the cytokines. So they are really the great performers of the immune response. They are the real regulators. And as we are going to see, overexpressed or underexpressed will be the deep cause of many immune disorders. Please take a note of the most important interleukins-based medications we can offer as GUNA pharmaceuticals. Interleukin-2, interleukin-4, interleukin-6. The two interferons we have, alpha and gamma, and interleukin-7. Now, please, let's go to be confident with the activity of each one of these interleukins. And then we will see a already prepared orchestra which contains all of these cytokines. By a pharmaceutical point of view, our medications are biotech pharmaceuticals. They are proteins and they are human recombinant in Escherichia coli. Just to have an idea, if you are not confident with the concept of cytokines, it's very easy. They are the words used by the cells to speak each other and, as I already told you, to lead the body physiology, in this case, the immune physiology. But it's not so easy to prepare these glycoproteins under the form of medications because only a very precise concentration is therapeutically effective. This concentration is equal to the concentration we have for these molecules in physiological conditions. I mean, in health. This concentration is picograms per milliliter, femtograms per milliliter. That is exactly the concentration you find in our medications. Why this slide is crucial in terms of understanding? Because you can see very easily that if the cytokines are hyperconcentrated or hypoconcentrated, they will be the onset of the disease. But thanks God, we can reduce the hyperconcentration or improve the hypoconcentration in order to reach the real goal of our therapy, that is the homeostasis of the immune system. We know exactly how these low-dose cytokines work. They work outside of the cell, upregulating the transmembrane receptors, as you can see in the left side of the slide, or, and this is one of our recent publications, they also are active in some intracellular signaling pathway. For instance, our gamma interferon is able to suppress a protein named SOX1, which is involved in switching off the activity of an immune cell. So it's easy to understand that if you neutralize the protein which switch off the activity of a cell, the cell will work much more, which is what we want to reach, for instance, during immune protection. So we know by a molecular biology point of view exactly how our medications are working out and in the cell. Be confident with each one of these immune regulators. Interleukin-2, first one. Interleukin-2 is involved in the activation of CD4 naive after the presentation of the antigen by the dendritic cell. It is one of the first discovered interleukin. At the beginning, it was called a growth factor. Why it is so crucially important? Because, as you can see in this slide, interleukin-2 is involved in the clonal expansion of CD4 naive activated. It's easy to understand that if you don't have enough interleukin-2, you will not multiply the precursors of CD4 naive. Instead, this way, you will have a clonal expansion. For instance, in elderly people, we have a suffering activity in the clonal expansion of naive CD4 positive. That's the reason why in elderly people, almost physiologically, we observe a sort of immune decline. So I can say interleukin-2 is the interleukin precisely designed under the form of GUNA interleukin-2 for the immunoprotection of elderly people. Some studies very well show that during aging, we have a progressive depletion of interleukin-2, especially after 50 years of life. And unfortunately, another interleukin, which is the marker of chronic inflammation, interleukin-6, after 50 years of age, start increasing. It's not nice when the two lines cross each other, because in that moment, you have an immune decline and a very severe chronic inflammatory condition. But now, create a sort of equal in your mind. Deficiency of interleukin-2 is observed in elderly people. So, GUNA interleukin-2 can be one of the medication to use in elderly people in order to protect them against infections. Interferon gamma, everybody knows interferon gamma. It is a beautiful molecule mainly involved in the cell-mediated immune response. It is able to activate a family of immune cells named CD4+, but still inactive in T cytotoxic cells. That's the reason why it is the effector of a cell-mediated immune response. T cytotoxic cells are able to kill a cell infected by a virus. And since a virus is a parasite, if you kill the hosting cell, you stop the multiplication and the replication of the virus itself. If interleukin-2 was a marker of immune activity in elderly people, gamma interferon is the marker of immune activity in kids. In this beautiful paper published on American Journal of Respiratory Critical Care in 2004, the researchers observed that if the kids under 1 year don't have, I hope you can see my pointer, don't have enough interferon gamma, they will undergo viral infections, respiratory recurrent infections, reaching 6, 8 in less than 1 year. Instead, if they have a good expression of gamma interferon, they will be totally protected against viral infections, especially the upper respiratory tract. So, can be important to provide low dose gamma interferon, which is totally clinically safe in kids, especially in those kids with recurrent respiratory infections. Absolutely yes. We will see how to do that. We need to be confident with interleukin-4, which is the interleukin produced by Th2 in order to activate B cells to produce antibodies. So it is used in cooperation between T cells and B cells to reach a good total immune response, in this case mediated by antibodies. Interleukin-6, you have seen that interleukin-6, when overexpressed, is the effector of the chronic inflammation. But since all the cytokines are neither good nor bad, when it works in physiological concentration, which is exactly the concentration we use in our medications, well, interleukin-6 is crucial for the differentiation of CD4 activated naive in T follicular cells. And T follicular cells are mandatory in order to have a good maturation of B cells in plasma cells producing antibodies. That's the reason why I wanted to title this webinar The Immune Orchestra. You see that all the soloists work all together in order to produce a beautiful symphony, which is a good immune response, a good protective immune response. Last but not least, interleukins I want to study with you is interleukin-7, which is quite pleiotropic. In fact, it is able to stimulate the replication of CD4 naive. It is important to stimulate the activity of T follicular, and interleukin-7, it's also important to maintain a good activity of the T cells memory, which protect us against a second infection. Unfortunately, we lose the immune competence with our aging because thymus in part progressively goes towards an atrophy. But interleukin-7, it is exactly the cytokine able to feed the thymus in order to recover a supplementary capability to reproduce and release T lymphocytes. It's interesting the role played by interleukin-7 in chronic viral infection, which lead normally the patient to viral persistence. And this viral persistence, it's mediated by an overexpression of a mediator named SOX3. But when we provide under the form of a medication, low-dose medication, GUNA interleukin 7, this interleukin, we block SOX3. So we block the viral persistency and we stimulate the viral clearance. So you have now a complete panorama of the range of cytokines involved in the immune response. What is beautiful that you have these molecules under the form of medications. Please keep in mind these four, especially these four interleukins: IL-2, IL-4, IL-6, interferon gamma. Why they are so important? Because they are the main effectors of the cell-mediated immune response during viral infections. This is an animated slide just to remember to you what happens when a virus attacks our cells. Immediately it is able to replicate and we observe the release of the new virions in order to attack other cells. But thanks God, Mother Nature, which is perfect, provides us with two immune cells named T cytotoxic cells, I already named them, and natural killer cells. They are the two cells able to provoke the specific and the aspecific cytolysis of the cell infected by the virus. Their mechanisms are quite interesting and are mediated by some substances named perforins, granzymes, that altering the osmotic balance are able
Alessandro, you are on mute.
Alessandro.
Alessandro, you are on. Alessandro, you are on mute.
I don't know what
why
happens.
it happens. Someone was muting me as well.
I guess someone mutes me. I didn't touch anything, but I have seen live now that someone mute my microphone. So please don't do it. Otherwise, it's a problem. Okay, I try. Do you hear me now, Stella?
Yes.
Okay.
And okay, now we are seeing your slides.
Okay, so please don't mute the microphones because maybe you are muting myself. All right. So we were saying how T cytotoxic cells and natural killer cells kill an infective cell by the virus through these important substances named granzymes and perforins. Why I told you, keep in mind some of those cytokines, and especially interleukin 2 and gamma interferon, because gamma interferon activating CD8 positive produce T cytotoxic cells. But gamma interferon also stimulate the activity of natural killer cells involved in the aspecific cytolysis. But natural killer cells are also activated by interleukin 2. So you understand that this couple of cytokines, interferon gamma and interleukin 2, are so crucial in the cell-mediated immune response. And 90% of our immune competence is due to the innate immunity and cell-mediated immune response. Unfortunately, and now we are going to see what happens in the patients, some patients, for several reasons, including genetic reason, are more susceptible to viral attacks. If you take a picture of the immune system of these patients, we will see that they normally have low levels of interferon gamma, interleukin 2, and all the immunostimulating cytokines, which are those ones provided by Th1. This way, the immune system is really under viral attack. And since the viruses are super intelligent, they are even able to condition the immune system in order not to attack them. I mean, viruses are able to downregulate the cell-mediated immune response through some immune escape mechanisms, which see one cytokine mainly involved in that, and it is interleukin 10. Please, my friends, when I say interleukin 10, I mean an overexpression of interleukin 10. That's the reason why in this slide you see interleukin 10 written in a so big character. Especially the overexpression of interleukin 10 induced by the viruses downregulate all the three types of interferons, alpha and beta, which are involved in the NK cells activation, and gamma, which is, as you know, involved in TC activation. So this is what the virus does. Always when they attack the body of every subject. So they do that. If we also have a genetic susceptibility to viral infections due to lower expression of interferon gamma, interleukin 2, and so on, that's really a big problem. So, by a therapeutic strategic point of view, what we can do? We need to increase the expression of interferon gamma. This is the first thing we need to do, because interferon gamma increases the cell-mediated immune response, which is the most important one against especially viruses. Influenza virus, paramyxovirus, rhinovirus, SARS-CoV-2, and so on, all the different types of viruses. This is a beautiful paper published on Science in 2020, where they observed that patients with some mutations in 13 genetic loci were more susceptible to viral infections because those 13 loci in the genes were not more expressing for enough gamma interferon. That was observed in patients with COVID-19. In the same family, they observed some go under the infections. Some others are protected, but they live in the same house. They are not in lockdown in the same house. So why some yes and some no? Some of them were not able to produce enough gamma interferon. That's the reason why, if I had to save just one cytokine for the antiviral activity, maybe I would say you interferons, no questions. Interferons are so interesting because they are not only involved in the immune system. In this paper published on Nature in 2016, you can see that gamma interferon is able to promote social behaviors. It works as a psychostimulant. That's the reason why when we are under viral attack, we are also psychologically depressed. This is really interesting, how beautiful and important is this molecule. So from one side, we need to increase the expression of gamma interferon against viruses, and we need to suppress the overexpression of interleukin 10, which is used by the viruses for their immune escape mechanisms. According to the concept of cross-regulation in immunology, we know that one interleukin is able to do that, interleukin 6. So look how beautiful is interleukin 6 when we have the physiological quantity, or you use GUNA interleukin 6. It is able to stimulate the follicular cells, and it is able to take under control the excess of interleukin 10 responsible of immune suppression. So my question now that we know the soloists of the immune orchestra, is it better to work surgically always with the soloist, or maybe it's better the most part of times to think in terms of many musicians, the symphony of the entire orchestra? The second, absolutely yes. And we have the immune orchestra. The name is CytoMix, which is the result of many, many years of studies in Italy especially. It is a multi-component medication where we have a core of ingredients. You can see them: interleukin 1 beta, interleukin 2, 4, 6, interferon gamma. They are totally involved in leading the function of innate and adaptive immune system. And since they are in physiological low dose, they are able to immunostimulate without provoking any inflammation. So let's go to see where every soloist in the orchestra of CytoMix goes to work. Interleukin 2, activated T cells. Interleukin 6, stimulate T follicular cells. Interleukin 4, stimulate the differentiation of T naive in B cells. Interleukin 4 is involved in the humoral immunity. Gamma interferon in the cell-mediated immunity. I mean, CytoMix is complete. It works on the innate and adaptive immunity, on the cell-mediated immunity, and in the humoral immunity. It is so sophisticated that even stimulate T follicular cells. I mean, this is a masterpiece in the immunopharmacology. I like to consider it a sort of pacemaker of the immune response, because you have seen all the relationships between all the different immune cells. So only if we work in the same time on the whole immune system, we will reach the goal of an effective immunoprotection. And let me say this: after 2.5 years of pandemic, and our country, as you know, was so strongly attacked by SARS-CoV-2, I can tell you that CytoMix saved thousands of lives in our country. So that's the reason why I speak about this medication with all the devotion, the respect, but also admiring this medication, because really we experience something important with it. But it is, please, if you not to speak now, and so we can go on. But in CytoMix, not only we have the core of ingredients able to immunostimulate, but it also has a strong anti-inflammatory soul, which is performed by some herbal extracts, Vaccinium vitis, Ananassa sativa, Hydrocotyle asiatica, and some Swiss organ preparations, which are specific of some immunological tissues, lymphatic vessels, medulla osseous, bone marrow, and thymus. So this way, we are able to stimulate and to keep take under control the inflammation that after the first invasion of the virus, we always observe. From our side also, we have the evidence of the research. In 2018, we published on Immunology Letters a very interesting preclinical study, basic research, which was oriented to measure the activity of cytomics in the modulation of both humoral and cellular immune response in an ex vivo study on children subjected to adenoid surgery. Think that this study has been considered so interesting by the Italian Ministry of Health that in the website of the Italian Ministry of Health, it is published, because it is a possibility offered by the Italian pharmacological research in order to protect Italians, but since you come from so many different countries, also your countries. The study design was very interesting. After surgery, we obtained the adenoids. We squeezed the adenoids in order to obtain the adenoidal mononucleate cells in the surfactant. And we measured the effect of our medication. Please look the results. First of all, we were convinced cytomics was active only on cell-mediated immune response, not at all. Also humoral response. In fact, please, the cells treated with cytomics are those ones of the black histogram. The other ones, gray histogram, treated with placebo, saline solution. You can see that our medication stimulate both be naive, be able to switch, already mature, and be switched. That means plasma cells able to produce antibodies, and always in a way which is statistically significant. Gamma interferon was our primary endpoint, and you can see how strong and how in a so important way the medication increase the expression of gamma interferon. So I absolutely can say we are stimulating the cell-mediated immune response. Interleukin-6, do you remember, it is important in order to downregulate the interleukin-10 that, when overexpressed, exerts an immune suppressive activity. You can see that, especially in the first moment of the administration, interleukin-6 goes up and then it recovers the homeostasis. But never forget that interleukin-6 in cytomics, it's not only important in order to bypass the viral immune escape mechanisms, but also because interleukin-6 is the messenger to activate, to make plasma cells producing especially IgA, which are the immunoglobulins located, for instance, on the mucosas, which are so important for us, so important in pediatrics. Interleukin-10 is downregulated, but we now know why. And this is the profile of immunoglobulins after administering cytomics. You can see that both IgM and IgA go up. Don't be surprised that IgG go down, because in immunology, this is the typical isotypic shift. Two subclass go up, one has to go down. But it's interesting that those ones going up are IgM, first immunoglobulins, and IgA, because we want especially to protect mucosas. We have a big experience in pediatric immune disorders with cytomics. I mean, this is the medications for everyone from 1 year to 100 years of age. But since the immaturity of the immune system in kids until 12, 14 years, this is one of the tools that Italian pediatricians use more than any other immunostimulating medication. I'm not speaking only in terms of homeopathic or low-dose medications, the complete proposal. This is something that I love because, you know, in our field we exist if we have the evidence. Please look at this number, 1, 2, 3, 4. 1, immunoglobulin A deficiency in children. So how much important are IgA? IgM immunodeficiency, number 2 in pediatrics. Number 3 article, impaired interferon gamma. Number 4, the role of interleukin 10 in the immune escape mechanisms. My friends, these are exactly the mechanisms we have studied about cytomix. So we can say that one drug, just one drug, cytomix, is able to improve IgA and IgM expression. It means that we will be more protected against recurrent acute bacterial infections. We use cytomix in managing allergic diseases. It improves gamma interferon, the paper number 3, the importance of gamma interferon in kids' viral infections. It is able to reduce early interleukin 10 expression in order to bypass the chronic viral infections due to immune viral escape. So really, just one medication, but so perfectly complete. Also, in the clinical trial performed more or less 12 years ago, where we compare cytomix versus bacterial lysates. At that time, bacterial lysates were considered a sort of gold standard in prevention of respiratory infections in pediatric age. Big number of kids, equally divided in 2 groups. One, group A, treated with cytomix, group B, bacterial lysates. You can see the number of upper respiratory infections in group A, cytomix, and group B. The delta in favor of cytomix is statistically significant, almost 1.89. Very interesting phenotypical outcome, fever. You can see that there is a strong delta between the 2 groups. That's when I told you it is able to immunostimulate without inflaming and to manage the inflammation. It's true. You can see the effect on fever. For pediatricians, the table 8, it's maybe one of the most important. The use of cytomix reduce the need of antibiotics, and it is statistically significant. You can see in the 2 groups, the delta is 1.04. IgA, we observe the increasing number of IgA in vitro, but the same we observed in vivo in the clinical trial. And this way also, this is a social outcome. The kids don't have to lose days of school and the parents working days. So really something that I strongly recommend you, especially in this time of the year. The kids treated with our medication, cytomix, didn't have to undergo surgery. Just 1 versus 9 kids treated with the bacterial lysates. These are the directions. Please take a note because it's important what we do. 5 granules under the tongue every day for at least 3 consecutive months. During the pandemic, personally, and all my loved ones and hundreds of people underwent cytomix continuously for 2 years. This is an important real-world experience because we see that there is no side effect also when you administer the product for so long time. Interesting is the scheme for the treatment of acute symptomatology when you have a viral infection. 10 granules, 2-3 times a day for 2-3 days. This way, the big quantity of granules manage very well, especially in the early stage of the infection, the disease. Even in this case, I'm speaking, having behind me a big, really big, real world experience. This is another study about cytomics, always in pediatrics, in the treatment of prevention of chickenpox complications, where we treated a group of kids with cytomics, and one group was the control, the negative control. 53 patients with cytomics, 53 the negative control. You can see the presence of respiratory symptomatology in the 30 days after the scab phase was only 9.4% in the group treated with cytomics versus 41.5% in the negative control. So we can really say that even in during the convalescence, cytomics is the North Star of our medications. In this case, if you are a pediatrician, this is these are the direction for chickenpox complication. Since they are very young kids, many times are sufficient 3 granules instead of 5, but better twice a day for only 30 consecutive days from the scab phase. In kids over 3 years of age, you can, no problem, also provide 5 granules twice a day, always for 30 consecutive days, starting from the scab phase. We also had a big experience, as I told you, in SARS-CoV-2 immunoprotection. And in this case, once again, 5 granules, once or twice a day. I recommend 5 granules twice a day, every day, for 3 months. Or if you go on for more than 3 months, 5 granules once a day are sufficient. Children under 6 years, already 5 pellets once a day, also for a restricted time period of time, 3 months. So which kind of take-homes we can say after the cytomics studies? That we have a wonderful possibility to modulate the immune response in totally clinical safety. We can slow down the virulence of the attacking viruses. And maybe the most important, we can really take under control the inflammatory symptomatology. In pediatrics, as I told you, it's so important, point number 4, the reduction of the antibiotics use. Also because those kids that undergo antibiotic use very frequently, they enter a sort of vicious cycle, and it's really difficult to free them from that. So just to wrap up, our goal in prevention through cytomics, in immunostimulation, 5 pellets a day or twice a day, every day for 3 consecutive months or more. Interesting, when the patient already has the symptomatic phase of the disease, that case 10 pellets 2-3 times. But please, it's so important, the time of administration. The early phase, it's absolutely the most important. What to do when you have the active phase, the inflammatory phase in a viral infection? Just remember that the first inflammatory phase is mediated by interleukin-1. The second part of the inflammatory phase by interleukin-6. And we need to manage these 2 moments. Never you will wrong using cytomics, also because still persist some viruses. But I give you some advice in order to manage that acute phase of the viral infection. In the early stage of the symptomatologic appearance, GUNA anti-interleukin-1 is the medication you have to refer to. After some days, when you are not more in the acute phase, GUNA-FLAM is the one you have to consider. It's important the use of GUNA anti-interleukin-1 in the early phases of the symptomatology with this direction. 20 drops arriving, as we did during COVID-19, arriving to 10 to 12 times a day until the acute symptomatology disappears. Look that anti-interleukin-1, GUNA anti-interleukin-1, since it works at the beginning of all the inflammatory pathways mediated by COX-2, PG2, and nitric oxide, is the medication which works in the same time as well as NSAIDs, corticosteroids, and salicylates. So it's really smart, the use of anti-interleukin-1 in managing the early stages of inflammatory processes. Instead, when you are facing a patient in the second phase of the inflammatory symptomatology, it's better to shift to another anti-inflammatory medication, which is GUNA-FLAM. GUNA-FLAM is a multi-component medication, and why I'm recommending it to you in the second phases, because it contains interleukin-10, which is, as we will see, the most important interleukin in order to downregulate the chronicity due to overexpression of interleukin-6. So if you will be good in managing by a chronobiological correct way these two anti-inflammatory medications, the goal will be yours. But we also to take care of the patients after an infectious disease. And now we have the big experience after the pandemic. But not only SARS-CoV-2 is able to create a sort of earthquake in our immune system. In fact, as you can read in this slide, after an infectious disease, and more or less persistent it is, we observe a subversion which is persisting in the immune system. And these are the markers. Increased interleukin-10, insufficient to suppress the inflammation. So the body is trying to react, but the interleukin-6 storm is so strong that our own interleukin-10 is insufficient. That's the reason why I recommended GUNA-FLAM, which contains interleukin-10. And we always have both T-naive and B-naive cells depletion. So it's really a bad moment for the immune system, a viral infection. So can CytoMix be useful for that? Absolutely yes. CytoMix can be the solution for the convalescence and the prevention of relapses. You know everything now about CytoMix. In this case, the directions are 5 pellets a day, every day, at least for 2 consecutive months. Look that you have to restore the immune system, because even an apparently lethal viral infection is a very bad moment for the immune system. We need to protect it, and CytoMix has been thought exactly for that. Another medication that you can use in overlapping with CytoMix, especially in adult and elderly people, I'm speaking about the time convalescence I mean after the disease, is GUNA interleukin 7. Do you remember? It feeds the thymus. It sustains the activity of B and T cell memory. In this case, we use 20 drops twice a day, even for 2 months, together with cytomics. After an infectious disease, we observe something that this is still actual, a subversion not only of the immune system. And we are facing, I think also in your country, a new pandemic, which is the post-COVID, long COVID, and unfortunately, even in children. And I told you, every viral infection, even more SARS-CoV-2, is a sort of nuclear bomb for our immune system. Why? Because even after the disappearance of the symptoms, there are a sort of earthquake waves after the earthquake, and all these waves are due to interleukin 6, which is persistent. Interleukin 6 is crucial for inflammatory processes because it is involved in the maintenance of the inflammation. And it is the marker of the low-grade chronic inflammation, which is the big enemy that as clinicians you have to fight against, the low-grade chronic inflammation. Also because after SARS-CoV-2, but now we can say, even though in a lower level, after every viral infection, because of the overexpression of interleukin 6, we have consequences in the brain, in the blood vessels, in the lungs. Just think to the fibrosis of the lung, in the heart, I mean, in the entire body. This is a beautiful scheme from a paper that shows how after any viral infection, the viral persistency, which means persistent inflammation, show upregulated mediators. Those interleukins that you know, especially interleukin 6, but also reactive oxygen species, which lead to pulmonary fibrosis and scarring, cardiac remodeling, I mean, really bad consequences. We need to prevent that. And we can do that because we have medications. We are able to manage the inflammation without immunosuppression. Why that's important? Because viruses are still there. So GUNA-FLAM, it's perfect. GUNA-FLAM, it's perfect. Interleukin 6 is so involved in fibrosis, and in no more than 10 minutes, I want to go a little more in depth in this concept. So, to be practical, what can you do to immunologically help people with long COVID? We are under an earthquake of cytokines, pro-inflammatory cytokines. Since these kind of viruses are able to subvert the balance of our immune system, we need to rebalance it. Cytomix, 5 pellets a day for 2-3 months. We need to support the antiviral response. And in this case, think of GUNA interferon gamma plus GUNA interleukin 12. When you use in overlapping with cytomix, you are doing the best possible work. For both GUNA interferon gamma and GUNA interleukin 12, 20 drops each a day for 2-3 months. Please take a note of what is appearing in the slide in red. Right, GUNA interleukin 10 plus GUNA matrix. These are the two medications which are perfect in order to counteract the fibrotic phenomena. That's the reason why we use them with a great success in patients after COVID in order to counteract the lung fibrosis, but also the kidney fibrosis, the cardiac remodeling, the brain fog. So with this simple scheme, you will support your patients, mainly in long COVID, but I can change the title in long viral diseases, because always any virus persists. We are having till now a good experience in overlapping therapy between low-dose medications and SARS-CoV-2 vaccines. And normally we act this way. From 7 to 10 days before the vaccination day, cytomix, 5 pellets once a day. And we go on at least for 60 days after the vaccination. In the same time, starting from 7 days before the vaccination, GUNA matrix, which is a very important support for the immune system. Since draining the extracellular matrix, we allow a better trafficking of the immune cells after the vaccination. And in order to avoid those side effects that sometimes it's possible to observe with the COVID vaccination, which are hypertrophy in the lymph nodes, especially laterocervical or acellular lymph nodes, we are used to recommend from the day of the vaccination, GUNA Lympho, I told you at the beginning of my seminar, 20 drops twice a day, at least for 60 days. I can tell you that we don't have a control study, but 90% of people undergoing this scheme of overlapping with the COVID vaccination didn't have any side effect. So it's quite experimented and quite good. Another medication that I want to present you, I think that the most part of you already know it, is GUNA Flu, which is our medication for prevention and treatment of influenza and parainfluenza syndromes. So cytomix is a wide range infectious diseases. GUNA Flu is specifically driven against influenza and parainfluenza viruses. It is very interesting because since, once again, it is able to stimulate the innate immune response and the cell-mediated immune response, and now you know what it means. And since the orthomyxoviruses of influenza are very genetically weak and so variable, they are able to drift. So very often the vaccine it's not able to cover since they drift, since the antibodies are 100% specific. That's the reason why the efficacy of the vaccine is in vitro 75%, but in the real world life 15 to 30% because of the drift. And you have to know that orthomyxoviruses of influenza are able to drift much more, for instance, of SARS-CoV-2. SARS-CoV-2 is able to do that one, influenza virus four times. So it's really a big problem. That's the reason why we are not so covered by the vaccine. And also we need to consider that only a little part of those diseases that we think are influenza are actually influenza, flu, because normally 263 para-influenza viruses circulate. So the most part of the infections are due to those ones and not to the real influenza ones. So we cannot have a vaccine with 263 strains. Instead, if we think in terms of a specific cell-mediated immune response, that's the best. That's the best. And it's not only Alessandro Perra saying that. This is the Journal of Infectious Diseases, which says that, look, that we have to think in terms of cell-mediated immune response more than in terms of vaccine for the prophylaxis of influenza. It is a multi-component medications, and we normally are able to identify two cores of ingredients. The red ones with an immunostimulating activity, and the blue ones able to manage the influenza and cold symptoms. Interesting, the immunostimulating activity of Anas barbariae influenzinum. Once again, you can see they don't stimulate mainly the humoral response, but the cell-mediated immune response, increasing the number of the killers of the cells infected by viruses. Both T cytotoxic cells and natural killer cells, but in this case, specific for influenza and parainfluenza viruses. Always the same mechanism of specific and aspecific cytolysis that we have studied. It contains also Asclepias vincetoxicum, which is a plant able to stimulate Th1 to produce gamma interferon, once again improving the cell-mediated immune response. You can see how beautiful is this association between Anas barbariae and Vincetoxicum officinalis. It's present also another antigen. It is a mix of antigens, actually. We call it influenzinum. In GUNA flu is particularly expressed one bacteria, which is Haemophilus influenzae. This is quite interesting because GUNA flu is not only able to prevent and protect us against influenza and parainfluenza viruses, but also it's able to protect against possible bacterial overinfections. In fact, as you know very well, Haemophilus influenzae is the most important agent of post-influenza overinfections. It contains also echinacea that even echinacea stimulate gamma interferon. You can see that all of them are driven to increase the cell-mediated immune response. And this is what we need against viral infections, especially against these kinds of viruses. Can we use GUNA flu and the anti-flu vaccine? Yes, no problem. We even love the concept of overlapping. 70% of the effect will be done to GUNA flu, 30% to the flu vaccine. You can decide. It's interesting also the role played by the ingredients. If you are homeopaths, you will appreciate the selection of aconitum, first phase of inflammatory process according to homeopathy, first phase of fever. Belladonna, second phase of inflammation, the vasal phase. Cuprum, which is involved according to the Materia Medica in myalgias and so on. So you can see how we can manage so well also the acute symptomatology. I will spend some words about the directions to suggest to reach the best results both in prevention and during the treatment of the symptomatology. Just you to look the effectiveness of GUNA flu in the management of fever during flu in comparison with paracetamol. In some countries you call it acetaminophen. It is not inferior to paracetamol in the management of fever. But please look at the inferior part of, of the slide. You can see that using GUNA flu, you manage the inflammation without immunosuppressing. In fact, the kids treated with GUNA flu had to use antibiotics for sore infections only in the 3% of cases. The kids treated with paracetamol, 24%, because paracetamol manage very well the inflammation, but unfortunately provoke also a little immune suppression. Interesting, this new approach, which is a global approach to the immune system. It's very important the way we administer the product. In seasonal prevention, one dose once a week for 6 to 8 weeks, to repeat after 2 weeks. This way, starting now, I recommend you now I will say you are, now you will see why. With 2 boxes, each box contains 6 doses, you are actually covered from September, October to February, March. Instead, if you use GUNA flu to treat the acute symptomatology, but you have to teach your patients to use it at the first symptoms in the early phases, within the first 36 hours from the onset, we recommend 1 dose every 6 hours until acute symptoms disappear. Why it's so important this year, especially this year, to recommend the use of GUNA flu, possibly even in terms of prevention of cold and flu with symptoms? Because SARS-CoV-2, my friends, didn't change only the life of us as humans, but also the ecosystem of viruses. So now, after the pandemic, we are observing that some viruses are stronger than before, and some others disappeared. And especially after SARS-CoV-2, 2 species are particularly aggressive. They are the rhinoviruses, attacking especially kids, and paramyxoviruses, type 2 and 4, attacking adult people. So even more this year, we need to prevent cold and flu. In this slide, you can see the trend of rhinoviruses infections, the red line, until 2020, before the pandemic. They were quite short. After the pandemic, please look, boom, the spike of infection in children younger than 10 years because of rhinoviruses. Interesting for us as adults, the trend of paramyxovirus is the red line. You can see then when SARS-CoV-2 goes down, immediately paramyxo goes up. In this moment, in our country, the infection of SARS-CoV-2 is quite low. It means that paramyxo are circulating so much. This is the moment for all of us, I think it's the same in your countries, to protect against this kind of viruses. Unfortunately, this year, there is an unusual and unpredictable circulation of rhino, paramyxo, and orthomyxoviruses. This is what happens in Australia, in the other hemisphere. And the trend is very different than in the previous year. You can see that influenza infections are attacking people earlier than usual. I mean, in Italy, the spike of the infection normally is in February, end of January, February. This year, we are expecting the spike in December. And you can see, you can see that there is a slope of the curve. It means that very possibly this year, the influenza viruses will be very aggressive. That's the reason why they prepare a vaccine with 2 new strains. It's nice, this term, twindemic, which means in the same time, the infection with SARS-CoV-2 and influenza virus. So we need to do something not to have these 2 girls attacking in the same time ourselves. We can do that very, very well, honestly, with the 2 medications you know now very well, Cytomix and GUNA Flu. But after this seminar, you also can act in a way that we can say precision medicine, combining, for instance, Cytomix, which is the orchestra, with a single cytokine. For instance, gamma interferon in kids, GUNA interleukin 2 in elderly people, GUNA interleukin 4 if you are using a vaccine in order to promote the activity of these cells. I think that now, after this time we have spent together, you really can manage those medications according to the concept of precision medicine. I would like to devote the last part of our webinar to the other side of the immune moon, which is the inflammation. But now that we know the mechanics of the immune system, it will be very easy, and I will go to the clinical application immediately, speaking about inflammatory diseases. You know that in healthy conditions, we have a perfect balance. How many times we have said that? So many. Between all the different T helper subsets. In inflammation, this is the picture of your patients. Th1 pathway is upregulated with upregulation of some cytokines that we already have named during the first part of the webinar. For instance, interleukin 1, interleukin 6, TNF-alpha, interleukin 17, everyone playing a precise role in the inflammation. So can we take under control all these different interleukins, involved each one in a different moment of the inflammatory process? This is the beauty of low-dose medicine. Yes, that's the reason why we speak in terms of precision medicine, but according to the physiology. We use, as many of you who already attended my seminars know, we use the concept of cross-regulation of the immune system. Recovering the balance in inflammation, since the main actors are interleukin 1, pro-inflammatory cytokine involved in the acute inflammation, interleukin 6 in the chronic inflammation, the range of medications based on cytokines we have are anti-interleukin 1, interleukin 10, and interleukin 4. Now we have to see how we use them. Okay, acute inflammation. Please take a note, because in a very easy way now, we will see how to manage a few different medications according to the timing of the inflammation. When we have an acute inflammation with calor, dolor, tumor, fluor, all the signs and symptoms, especially fever and pain of inflammation, it means that interleukin 1 beta, which is responsible of the onset of inflammation, is dramatically upregulated. Dramatically upregulated. This is the picture of the immune system of your patients during the first 72 hours from the onset of the inflammation. Interleukin-1 up, up, up. As I told you, GUNA anti-interleukin-1 is the medication. It is a monoclonal antibody specifically indicated for acute inflammatory processes. It is so effective in the management of fever, and I can tell you it is very effective against pain, benign pain. In fact, it is able to downregulate also the P substance, which is involved in the peripheral pathways of the pain. Just think that using GUNA anti-interleukin-1, since you block interleukin-1, you will be blocking all the three pathways of the inflammation, which lead to the production of prostaglandins, nitric oxide. So in the same time, using GUNA anti-interleukin-1, you will be using NSAID, corticosteroids, and salicylates. So if you like the image of the balance, acute inflammation, marker, interleukin-1, solution, monoclonal antibody, anti-interleukin-1 beta and alpha. Commercial name, GUNA anti-interleukin-1. It's so important that you have clear the directions. In fact, since interleukin-1, marker of acute inflammation, has a half-life very short, doesn't make any sense in the management of acute inflammatory diseases to use a GUNA anti-interleukin-1 for months. But it's better to think in terms of 10 drops every 30 minutes until acute symptomatology disappears. Interesting in pediatrics for the management of fever instead of paracetamol, but in many other possible applications that you know very well. In chronic inflammation, the markers and the big enemy is the dramatically overexpressed interleukin-6. I like always to picture interleukin-6 as the secret killer. And why we need to take under control interleukin-6? Because, my friends, when you have an inflammatory process in a tissue, that's not a problem only of that tissue, but from that tissue, this is the New England Journal of Medicine, we always observe the spreading of the interleukin-6 all over the body. So not treating a low-grade chronic inflammatory process in a tissue means to increase the possibility to have cardiovascular diseases, neurodegenerative diseases, osteoporosis, sarcopenia. All of them are related to overexpression of interleukin-6. And unfortunately, what all the systems are involved, all the organs, all the tissues are sensitive to the activity of interleukin-6. So whatever specialty you have, this is something that I recommend you to think of and to find a solution. Think that even negative emotions can provoke inflammation. This is what you can see in this beautiful paper published on brain behavior immunity in 2013, where you can see the marker of chronic inflammation, interleukin-6, and its increasing trend according to the increasing negative emotions, especially if we live in an interactome, in relationships with other people which are provoking stress to us. Just to laugh, to smile at least. Do you know that when love ends, it makes you inflamed? In fact, when the love of our life ends after years of dopamine, storms of dopamine in our brain, making us living so well. Dopamine goes down. The downregulation of dopamine provoke negative thoughts. Negative thoughts are related to increasing interleukin-6. But recent studies also show that the drop of dopamine we observe during the end of a love story provoke the activation of the inflammasome NLRP3 that is responsible through some pathways mediated by caspasis-1, interleukin-1 of peripheric inflammation. I mean, my friends, it's true. When your patients, when a love ends, comes to you and says, I feel pain everywhere. It's not only pain in the soul, it's pain in the muscle, it's pain in the joints. Now we know why. And interleukin-6 is involved on that. Take care of your patients who are in overweight or obesity, because adipocytes are mines, reservoirs of interleukin-6, and not only interleukin-6, CRP, TNF-alpha, leptin. So it's really dangerous, the overweight. Take care of your patients over 50 years of life, because unfortunately, physiologically, in every human being after 50, interleukin-6 starts going up, and he will go up till we will die. So if we want to live more, we need to downregulate interleukin-6. Take care of your patients after COVID-19, but in general, after any infective diseases, because always we observe the storm of interleukin-6. Interleukin-6 is directly related to fibrosis. And be careful using medications such as NSAIDs for a long time, because you block the inflammatory process, but you don't resolve the inflammation. And unresolved inflammation are triggers for fibrosis, because you don't allow the shift between macrophage M1 and macrophage M2. We now know exactly this kind of process. And if we don't manage very well this shift between M1 and M2, we make a fibroblast becoming myofibroblast. And this is the beginning of the end, the beginning of pro-fibrotic mechanisms. What can we do to take under control interleukin-6? We know by immunology that according to the cross-regulation processes, interleukin-10 is the antagonistic of interleukin-6. We are saying this since 20 years, but now all the medical environment is going in that direction. Look at this paper, Biology and Therapeutic Potential of Interleukin-10. Targeting interleukin-10 family cytokines for the treatment of human diseases is the dream of every pharmacologist, to have a medication based on interleukin-10. We have it. That's the reason why it's so important, this meeting, to share experience. We have experimented both in vitro and in vivo in clinical trials interleukin-10 in many diseases, in IBDs, in rheumatoid arthritis, in psoriasis, in vitiligo, in so many diseases. And now we can say that low dose interleukin-10 under the form of drops, GUNA interleukin-10, are definitively effective in the management of chronic inflammatory diseases. In this case, my friends, please take a note of the directions to use in terms of administrations. 20 drops GUNA interleukin 10 for a long time. I mean, 2 to 4 to 6 consecutive months. It depends by the age of the patient, by the clinical history of the patient. This is, I think, one of the most medications we have. It is able to counteract the fibrosis, the tissue fibrosis, especially when used, together with another medication, which is able to take under control the ECM, extracellular matrix rigidity, which is the consequence you can see of a low-grade chronic inflammation. So the perfect combination in order to treat your patients in long COVID with fibrotic evolution in the lungs, in the kidneys, wherever, is GUNA interleukin 10, 20 drops twice a day for a long time, plus my beloved GUNA matrix, the multi-component medication devoted to clean and drain the matrix, but now we like this term used by histologists, plasticity of the matrix. Plasticity of the matrix is the opposite of fibrosis. We know exactly how this medication works, supporting the plasticity, counteracting the rigidity, especially because of the presence of pyrogenium, which is able to stimulate the activity of some enzymes involved in the remodeling of the extracellular matrix, the metalloproteinases, and hyaluronidases, you can see in the blue cycle. And we have the evidence from the preclinical study, the basic research, where you can see that with GUNA matrix in a culture of human dermal fibroblasts, we dramatically increase the expression of metalloproteinases, which are the most important enzymes involved in ECM remodeling. So what was our hypothesis have been confirmed by the basic research on that. GUNA matrix, 20 drops twice a day for 4 to 6 months. And perfect is this combination in counteracting fibrosis. 20 drops twice a day for both 4 to 6 months. We have a lot of experience in some of very bad, especially autoimmune diseases, like rheumatoid arthritis and or psoriasis, vitiligo, gout osteoarthritis, and we have the evidence about that. So please ask us, GUNA, export department, scientific department, all these studies, because we can give also the protocols for that. But for me, it was more important today to see with you the concept in order to make you able by yourself combining these medications to treat all the different patients. Also in inflammation, it's interesting because now you know the tool for the acute inflammation, GUNA interleukin 1, the tool for the chronic inflammatory diseases, interleukin 10. Never forget GUNA interleukin 4. That is the medication you always have to think of when your patients show an autoimmunity. Interleukin 4 is specific to downregulate the overexpression of T helper 17, the markers of autoimmunity. So with these 3 interleukins that you can use all together, as we do in all the autoimmune diseases, or as single according to the chronobiology of the of the inflammation, you are able really to do a great job. It's already 2 hours we are together, and our time is it's enough. But so now I'm ready for all the questions you would like to ask, but also saying something that is, please, my friend, this is just a part of our educational pathway together. If you like this webinar, in a very short time, with my colleagues of the export department, we can set up a second part where we will see the protocols for autoimmunity with our experience in those diseases I mentioned before. And also we will see what to do for the third side of the moon. First side, immunodeficiency. Second, inflammation. Third, allergies. So I'm ready for any question, and I ask my friends and colleagues of the export department if they can read them, and I will answer them.
Alessandro, there is a question from South Africa.
Yeah.
The question is it safe to use GUNA flu and cytomix in pregnancy and lactation?
Yes, we don't have any advice, any contraindication in both pregnancy and lactation. Never forget that all the ingredients, both herbal extracts, animal extracts, and interleukins in cytomix, nosodes, and classical homeopathic remedies in GUNA flu are always in low dose. So they are not able to, in any case, affect in the wrong way the immune response. So my answer is 100% safe. Also because beside what I'm telling you by a strictly immunological point of view, there is the evidence of over 25 years of use in our country that where never we received any warning by a patient.
May I have a question, Alessandra? Hello, this is Hatis from Turkey.
Hi, Hatis, how are you doing?
Hi, hello, thank you. And you, I'm very happy to listen your webinar. Thank you very much. And I had a small study before the webinar about the products, and I would like to ask from which animal are you taking the animal originated extracts in the in GUNA flu and the other products? Is that swine origin?
Okay, for what it concerns the cytokines, they are biotech, human recombinant in Escherichia coli. For what it concerns the extracts, they are swine origins, and the herbal extracts are herbal extracts.
Okay, and in our country, I have had a small research about how to take a homeopathic drug permission before your webinar, and I understand that we have to submit a file, it's a file which is like a drug file, a little bit different, but there are modules, etc. So do GUNA products have those necessities to submit as a homeopathic drug?
Yes, it's not my expertise, but I can tell you that we have all the documents, the CTDs, I think they are called, and they are registered in the countries as homeopathic medications. Yes. But since it's not my field, I don't want to say something it's not totally correct, but the people, my friend and colleagues of the export department, they have an office totally devoted to the regulatory, so they will help you totally. Also because it's important to import in your country this product. I was in Istanbul very recently, exactly 1 week ago. You cannot imagine in this Congress where I spoke, the interest for the low dose cytokines. So can be a big opportunity.
Oh, I hope so. Okay, thank you very much, Alessandro.
You're very welcome. Isam, can you read the other
Yes.
questions?
I'm going through. Liliana is asking, can GUNA matrix and interleukin-10 be used for 1 year or more without stopping, or it's better to pause, and for how long?
Okay, good. There is no any contraindications also for the use for a long time. For instance, all these medications, which are low dose medications, I experienced the use of Cytomix consecutively for 2 years. But so you don't have any side effect, any over dosage, I mean. What I recommend in the management of chronic diseases, for instance, in the case of the question, interleukin-10 and matrix, maybe in the management of chronic fibrosis, is that you can use for 2-3 months the combination, and then for 1-2 months you stop. Why I tell you this? Because you have also to consider the compliance of the patient and the adherence to the therapy. I mean, some patients can become bored taking medications all the days. But why it's very interesting this way? 2-3 months yes, 1-2 no. 2-3 yes, 1-2 no. 2-3 yes, 1-2 no. Because what we have observed always in all our 11 clinical trials is the effect that in experimental medicine is called carryover effect, which means that even when you stop the administration, the patient still improved. So we are covered, even though for 1 month, after 3 we have administered the medication, we don't give the patient the medication. So I recommend 3 yes, 1 no, 3 yes, 1 no, 3 yes, 1 no, according to the kind of patient.
Okay. A question from Marina. Is it safe to prescribe Cytomix to children under 2 years of age?
Yes, we have experience also under 3 years of age. In that case, are sufficient 2-3 pellets, but not because 5 are too much, but because they already respond to a smaller quantity. But since you have seen the composition, it is very balanced. Even though the immune system is still developing, you help an harmonic development of the immune system. We have already designed a clinical trial in kids with recurrent respiratory infections, and also kids under 3 years of age will be enrolled. So no problem.
Okay. No more questions in the chat box.
All right.
Good evening.
Please.
Okay.
I am Urjwana from Palestine. I want to ask you a question. If a patient take such as interleukin 10 more than 40 drops in a day.
A day, you mean Alzheimer's disease?
A day.
A day.
A day. If you use even 100 drops, you don't have any side effects, but they are not useful. What is useful for the body is the quantity of 40 drops. And now I tell you why. 40 drops of our medications are about 1 milliliter. The concentration of our products is 1 picograms per milliliter. So when we give 40 drops a day, we are providing the physiological quantity of this kind of glycoproteins. So if you give more, you are doing something unuseful. Stay on 20 drops twice a day, or when you prescribe a protocol with more than one medication, in order to improve the compliance and the adherence of the patient, you can put 40 drops each product in a little bottle of water, 30 centiliters, to drink during the day. Please always remember to recommend the patient to keep the content of the medication in the mouth for 30-60 seconds before swallowing, in order to have a mucosal absorption, which is perfect for the alcohol concentration of our medication. It supports the perfect absorption in the mouth.
I want to ask, thank you for your explanation, but I ask if somebody else take it more than 20, he will have any side effect, any toxicity. I'm just asking about this.
Okay, it depends. If you drink the whole bottle, maybe you will have some discomfort for the alcohol. But in terms of immune response, you don't have a side effect. Okay?
Okay.
I mean, if you use 100 drops, you don't stimulate more Th1 immune response. Okay, but why? Why to take more? We say 40 drops because 40 drops on 1 milliliter, and 1 milliliter contains exactly the physiological concentration of this molecule in your body. It means that at that concentration, they physiologically work. So it's not casual 20 drops twice a day.
Okay. Another question is if there is any studies on cytomix for adults. I read more than one study, and all of them are about children or like this. I want to ask if there is anything for published study for adults.
No, we don't have in a clinical trial about cytomix in adults, but we have the real world experience in 25 years. And you know, which is your name? Your first name?
Orshwana. Yeah.
Orshwana, you know which is our biggest experience, unfortunately, during COVID-19. During COVID-19 and yesterday, we released a webinar in Italy for hundreds and hundreds of Italian doctors, where 4 speakers spoke about their experience in COVID and long COVID. And one of these, named Andrea Lozzi, an hero because he was the doctor who worked in the little village where in Italy everything started. At that time, they didn't know anything about SARS-CoV-2. But with cytomix, his patients, only 3 of his 1,500 patients died. 3 out of 1,000. I cannot say because of cytomix, because this is a real practice, not controlled. And the most part of them were not adult, but elderly. And do you remember that in elderly people, we have a sort of physiological deficiency of interleukin-2, which is the trigger of immune decline? Well, in cytomix, there is exactly also interleukin-2. So by an immunological point of view, it is perfectly designed, both for kids and adults. We don't have a study till now.
Okay. A question, if GUNA flu can be used instead of influenza annual vaccine in children?
Excuse me, something
if GUNA flu can be used instead of influenza annual vaccine in children?
Okay. we cannot say that because some categories of patients need to undergo flu vaccine, for instance, cardiopathic and so. In Italy, for instance, we are 60 million people, and the flu vaccination is not very used, but it depends. We cannot say avoid the vaccination and use GUNA flu. Any doctors has to evaluate which is the case for the use of the vaccine, the use of GUNA flu, or, as I told you, the overlapping. The most part of people in good health can undergo GUNA flu, no problem. But I wouldn't be serious to saying, okay, avoid the vaccination. It depends by the patient.
Okay. Any more questions? No questions so far.
All right.
Okay, if there are no more questions, thank you very much for your participation. Thank you for joining our webinar. We will share some information like the studies mentioned, and we hope we can organize a part 2 for this interesting webinar. Thank you very much for joining us, and have a nice rest of the day.
Thank you.
Thank
Thank
you.
you very
Thank you.
much.
Bye bye.
Very much. This was excellent.
Bye. Thank you.
Very
Take
beneficial.
care.
Ciao.
Thank you.
Ciao.
Ciao.
Muchas gracias. Buen día a todos. Adiós.
Muchas gracias.